Hi, everybody. Hope you're all well. Thank you for all of you joining directly here on the meeting. And remember, at any time, you're more than welcome to stop, ask me questions, clarification, things like that. If you're watching it later, you can always ask me questions on the WhatsApp group, Telegram groups, or even directly in the YouTube comments, and I'll try and answer as best as I can. So today we're doing another ECG. And it's quite an interesting one. So I hope that you enjoy it. And what I've been doing recently is I've been trying to find ECGs that uh, have patients with very vague and non-specific symptoms, so that you can see the value of doing an ECG for these patients and how it can very quickly cut down your sometimes your diagnosis time and help you even to get a proper diagnosis in a very short period of time. So let's have a look at today's patient. So I hope you all had the chance to see the ECG on the group. If not, we will go through it now. So just get this up here. Okay, there we go. So here we go. 54-year-old male patient presents with 5 days of anorexia, nausea, and vomiting. So at 54 years old, there's a lot of reasons why a patient may present like that. And, it depends on what you find physically as well on the patient. For instance, a diverticulitis would be quite high up, maybe even appendicitis, but generally you'll find those patients have quite a bad acute abdomen as well. The patient may have a history of, pharmaceutical use, may have had recent travel history. The patient could just have had a simple case of food poisoning. So there's quite a bit that could be there. But let's say, you're not 100% sure on the diagnosis, so there's no definitive diagnosis. And as part of your workup, you do an ECG, and this is what you find. So there's a few things that may strike you immediately, that may make you a bit suspicious that something else might be going on. And the most probable are the T waves when you look at them, because you can see they're very flattened throughout, and they don't really pick up any sort of my apologies. There's a very bad storm here in Newcastle at the moment. So if you can hear a lot of rain and wind at the back, I think we're having a bit of hail as well. So yeah, my apologies. I'm trying to speak as loudly as possible so that you can hear me. So this might be one of the things. You might even notice that the QT interval looks a bit long. So these may be some of the things that actually come to your mind, but it's not a particularly worrying ECG when you just look at it. For example, there's no outstanding features of ischemia or anything along those lines. Apologies, I'm just going to try and deaden the sound a little bit. I'm not sure if that will help at all. Move a bit away from a window. We've been given a weather warning here in Newcastle that it's going to be quite bad overnight. So my apologies if it's making a lot of noise there in the background. Okay. Sorry, just try to move to an area where it's a little bit quieter, but not much. Okay, so let's go through the ECG. Now, what I mean is when you look at the ECG at first glance, there may be something. So, for example, you may say, this biphasic T wave, and okay, Dr. Mohammed taught us about Wellens, could there be something going on there? So it's an ECG that you might take a minute just to have a look at rather than just doing to put into the file. So if we look first at the axis, so we've got leads 1 and AVF, and lead 1 is mainly positive and lead AVF is mainly positive. So we can say that it falls within the normal axis for the patient. If we had to look at the rhythm, we can see there's no rhythm strip on this. The reason being the authors of the book that we are using didn't actually consider this to be a rhythm abnormality, but nevertheless, we'll go through the rhythm using lead 2 as we normally do. So one of the things that you notice that you've got a slightly biphasic P wave over here. And in fact, I'll just show you something. Here you can see a notched P wave. So whenever you see a notched P wave, it normally indicates an atrial enlargement. In this case, it's the left atrium. Sometimes it may be the right atrium as well, but in this case, it's the left atrium. And generally in emergency departments, atrial enlargement is not a huge worry for us unless clinically we suspect a valve problem or we are suspecting, Well, majority of the time, I suppose it would be a valvular problem or a either a stenosis or a regurg. But then again, it's just for the purposes of completeness. It's not going to really dictate our management on the patient. If we had to look at our QRS complexes, our PR interval, we take it from about middle here, 1, 2, 3, 3.5 to 4. So that's within normal. Our QRS complexes are quite narrow, and the QRS follows every P, and it's also quite regular. And you can see that throughout. So it's a relatively normal rhythm. So we put it as a sinus rhythm with maybe a bit of an atrial abnormality. If we had to look at the rate, we'll just work it out now. So 1, 2, 3, 4. So that's 75 beats per minute. So this patient is not tachycardic, not bradycardic, and generally everything looks okay. So let's have a look at our inferior zones now. So if you look at leads 2, 3, and AVF, the one thing that stands out are these T waves that are very flattened, as you can see here. And if you look at it, it looks as though the distance from the QRS complex to the T is actually quite long. Now, the exact measurement would be normally at the top of your ECG, strip, and you'd have something called QTC, which is the better one to use. That's the QT corrected. So the QT corrected actually deals with the tachycardias and bradycardias, and it tries to give you a QT distance based on the rate of the patient as well. Because, for example, in a bradycardia, you may have this elongation, but it may not necessarily be pathological. And in a tachycardia, you may have what looks like a normal distance, but for the tachycardia, it's actually pathological. It's not something you'd use very often in the emergency department. It's more for the cardiologists and physicians. But the one clue that it gives us is when you have these slightly longer QTs. So even though here it looks relatively normal, but here you might suspect that it looks a bit long. And anything above 450 milliseconds is something that you should be worried about. Now, it changes between male and female, but in the past, I know I mentioned it and people have always struggled to remember it. So I just say 450. Remember that as a baseline. If it's above 450, just think that it's elongated. So when you have an elongated QT, you've got to start thinking of the hypos. So hypokalemia, hypomagnesemia, hypocalcemia, anything that could possibly go hypo in terms of your electrolytes. So this is a possibility. And if you look at a patient who's having anorexia, nausea, and vomiting for 5 days, you would suspect that some of the electrolytes are down. You may even suspect the patient may be alkalotic now, having lost a lot of the hydrogen ion. There may be something else going on, just sheer fluid loss. Could lead to hypokalemia and hypocalcemia and things like that. So that's what we can pick up from the inferior zone. When we go to V1 and V2, as we can see, we've got the main thing is sort of like this notched T wave. And it looks as though we've got another wave that's coming out after that. As compared to, as I had mentioned earlier, Wellens, and Wellens being one of the things that I had taught you guys before. I just want to try and get a nice color over here. Sorry. So we had talked about, biphasic T waves before. And generally the difference between this, which we can see, and a biphasic T wave is in a biphasic T wave, you tend to get this, and then it goes back to normal. So in other words, you've got a T wave that's biphasic, but it goes back to normal. Whereas if you follow this one, you can see it's got a wave, and it's got another wave. All right. So this is something that we call a U wave. All right. So that's what we are seeing over there. So the U wave is quite indicative again of hypokalemia, which is something that we have to suspect in this patient, considering he's had 5 days of GI disturbance. Now, diarrhea, of course, is much more commonly known to create hypokalemia, but nausea, vomiting can definitely also lead to that. So we can see that even though this is a relatively mundane ECG, it has clues as to what's going on. So if we come to V3, here we can see it as well. We see this double hump, so to speak. If we come to V4, not as apparent. Here it looks more like a biphasic T wave, but there's maybe a small T followed by this U wave, and we can see that pattern repeating itself. And when we come to leads 1 and AVL, here you could possibly see that there's a double wave. So this double wave that they are talking about here, if you had to just isolate it, it looks very much like a camel's hump. And the camel hump appearance is quite indicative of hypokalemia. Now, does it confirm hypokalemia? No, it doesn't confirm hypokalemia, but it is something that we should be suspicious of. So if you were to see this as compared to, let's say, just a normal biphase, I apologize for my drawings. I know they can be quite terrible at times, but if you can imagine this just going up, down, but then just flattening out as compared to this one that goes up and then seems to go up again into a camel's hump type of configuration, which you can almost imagine over here as being, the dromedary camels that have a double hump. That's kind of what it looks like. So this is the type of patient that now once you see this, you will suspect, okay, this could be hypokalemia, but it could still be hypocalcemia, hypomagnesemia as well, because he's a relatively older gentleman, 54. There could be some conduction abnormalities going on. So, it's the type of patient that would prompt you to say, okay, I need an urgent UNE to see what I need to do. And very often, especially in patients who are having GI losses, it's very uncommon to have a single electrolyte drop down. You may have one, you may have two, you may have changes in your sodium. So and remember, sodium and potassium have an inverse relationship. So if your potassium is low, generally your sodium starts to increase. But from all of these, the one that you'd be worried about the most would be potassium and calcium. All right, so let's move on and have a look at the answer and see how close we actually get to the final answer on this patient. Right. So as we said, a sinus rhythm with a rate of 75. It's got a left atrial enlargement, which I'm not too worried about now. So non-specific T wave flattening in the inferior leads, which we had seen, and U waves in the precordial leads. So that's what we were talking about here, V2, V3, V4, not as apparent on the others, which is suggestive of hypokalemia. Now, if you want to, it's good to know these types of things, how to diagnose, for example, a left atrial enlargement and how exactly you go through the entire thing. But I must be honest, this is not something that you would concentrate on in the emergency department, especially at most of you guys being at the medical officer level, maybe reg level, student level, intern level, comserve level. It's not something you're going to stress about too much, but it's a nice thing to know. And it's the type of thing that if you mention it on a ward round, you've got a good chance of being right. So you'd look very intelligent, but it's not going to change your management of the patient in any way. So the prominent U waves, like we said, it's suggestive, but remember, it's not pathognomic for hypokalemia. And this is a mistake people often make. When they do see U waves, they immediately assume it's hypokalemia and nothing else. It doesn't necessarily mean that. And as we had said, it's got a camel hump effect, and that's how the T waves look. And on occasion, if they are fused, they produce the appearance of a prolonged QT interval. So that's what we were seeing here in these inferior leads. So especially in lead 3 and 2, you can see because it fuses, it gives you this impression of a very long QT. But here when you realize it's not really elongated. But these are just little details and things that if you pick up are great. But the main thing is that if you pick up, there's a suggestion that there could be an electrolyte abnormality, even if you can't pick out the exact abnormality at the time of ECG, but it shows you the value of using an ECG to try and possibly come to these diagnoses. So other ECG abnormalities associated with hypokalemia, and this is where we get into a problem, premature ventricular contractions and ventricular dysrhythmias, ST segment depression and decreased T wave amplitude. These are all to do with the ability of the myocardial membrane to exchange sodium and potassium to create an action potential. So as you can imagine, with decreased potassium, there's a decreased ability for the cell membrane to create those action potentials. And that's why you start seeing these. The one thing I wanted to point out as well, as compared to hyperkalemia, where you can sort of judge the level by the severity of the changes, in hypokalemia, you can't really. So for example, even if we said that this was a hypokalemia, you couldn't be able to say, okay, I suspect it's in this range based on this appearance of the camel hump. So that's one of the differences between the two. Now, the ventricular dysrhythmias are the ones that we worry about the most. And I can tell you over many years of having done this, that It's the most common complication that I've seen. You get patients who go into sudden cardiac arrest or sudden ventricular dysrhythmias, and the more quickly that they're going into dysrhythmias, or the more frequently you have to get them out of a dysrhythmia, tells you how severe the hypokalemia may be, or the hypocalcemia and things like that. To give you an example, we had a patient, I think about 6 or 7 years ago. It's one that sticks out in my mind. It's a gentleman with a rectal prolapse who was just leaching fluid from the prolapse. No matter how many times we tried to relocate, he kept on coming out, and he would keep on leaching his potassium out from there. And he went into a cardiac arrhythmia almost every 10 minutes. So we would immediately, give him a good precordial thump, start him on antiarrhythmetics. But no matter what we did, and actually no matter how fast we were replacing the potassium, he kept on going back into dysrhythmias. And the patient ended up in ICU. And even under ICU conditions and with replacements and things like that, until they did the rectopexy, or until they put his rectum back into place, he continued to leach and leach and leach and have arrhythmias on a very regular basis. And my understanding is that even after the rectoplexy, even though it wasn't as pronounced, he still had hypokalemia, and it took quite a few days to actually get him out of it. Now, of course, that's not something I've only ever seen it once in my entire career, so it's not something you can expect. But I'm just saying, it can get quite bad, and the GI losses are the ones that often cause a major problem. So how do you manage hypokalemia? Now, you're sitting in your emergency department, you know that your patient has hypokalemia, you've checked your potassium levels, you've got all of this. So you've just got to, first of all, decide, have I got mild hypokalemia, moderate, or severe? The other thing that you've got to know when you enter your emergency departments, especially if you're going to be spending a bit of time there, if you're somebody who's going to be spending a year, maybe 2 years or 3 years, you should get to know your department protocols. So, for example, with us at Madadeni, any patient below this 2.5 cutoff is actually meant for ICU. And anybody with a hypokalemia in an acute setting must be assessed by the physician. They are the ones who make the decision on what type of care they want and how high care they want, or ICU or the ward. But we, for example, under 2.5, 2.4, we automatically assume the patient is for ICU, and we start preparing the patient as such. Now, your hospital may, for instance, say, no, less than 3, we consider the patient. But most of them, around this area, you'll find that that's what your consultant or head of department will decide is the most serious. So you can decide whether you've got mild, moderate, severe K plus abnormalities. But in an emergency setting, it doesn't mean that you disregard mild potassium abnormalities. We have to treat all of them. So the most common causes, like I said, were GI losses, and more common is diarrhea as compared to the upper GI, so nausea and vomiting, but both do cause it. Renal loss is very common as well, especially when you've got certain renal tubular diseases and things like that, inefficient exchange mechanism. Your patient can actually lose quite large amounts via the kidneys. And of course, diuretics. So your Lasix being the most common one that most people know, but there are a lot of, not a lot, but there are a few others that do cause it as well. So once you've decided, okay, my patient has, for example, mild, moderate, or severe, then you decide how you're going to replace. Now, the literature says mild to moderate hypokalemia. This is why I put it like this: oral potassium supplements. In practice, in an emergency department, I would suggest always going for IV potassium replacement. It's just the rate at which you're going to go that may change. But according to the literature, you should be considering oral potassium supplements initially, and only consider IV potassium replacement for severe hypokalemia. The reason why I mention in an outpatient setting, you could think of this, or a patient who's in a renal outpatient, things like that. But for any patient who's coming to the emergency department with an acute problem, it's very unlikely that oral potassium supplementation is going to help them get back into normal, because you haven't necessarily sorted out the acute problem. So the question comes about, how do I give potassium? So you've got, potassium chloride. You've got a few different variations of it, but they tend to come in 1 amps of 20 millimoles. So the most common way to actually give it, I'm sorry, I just want to annotate this just so that we've got it over here. Sorry, just want to put that here. All right. So the most common way to give it is to give it at 10 millimoles per hour via peripheral IV. All right. Via peripheral IV. This is the safest way to give it. And another way of putting that is half an amp per hour. All right. So half an amp mixed with 200 moles of your Ringer's lactate, sodium, normal sodium, whatever, normal saline, whatever you have. But this is the most common way. So I would say for mild to moderate hyperkalemia, if you replace in this manner, it's very unlikely that you're going to run into trouble. However, if you've got a patient now whose potassium is maybe 1.9, 1.8, is at high risk, you need to up that to 20 millimoles per hour. The problem is that if you try and give that via peripheral IV, there's a few things that are going to happen. Number one, it's going to be very uncomfortable for the patient because the potassium does burn as it's going in. And the second thing is that you're actually putting the patient at very high risk for renal and cardiac complications. I won't get into it in too much detail now, but just remember that. So this is given via central line. So CVP. All right. So this is the most common way to get a lot of potassium into the patient safely. Now, can you give it at higher rates in an ICU setting? But even there, I haven't seen them go more than about 30 millimoles per hour, and with the patient on, very strict, uh, monitoring and, constant ABGs, and there's a lot of things that are going on. But this is the most common way to replace it. So you're not trying to rush KCL into a patient. The reason for that is another name for rapid KCL infusion is a lethal injection. This is how they execute prisoners, is one of the things that's given is KCL. So a large amount of KCL given very quickly will cause cardiac arrest. So please remember that. Okay, so do not administer, like I say, a lethal injection. All right. By giving it so quickly that you actually cause a problem. The truth is that if you give it at these levels, 10 millimoles per hour via peripheral IV for mild to moderate, or 20 millimoles via central line, you'll never run into trouble. Never. You'll never get into trouble. Just don't give it quickly. And your own institution may have slightly different protocols, but majority would follow something like this. And like I say, you avoid IV bolus as well, not just for the risk of hyperkalemia, but also, sudden cardiac arrest. Now, one of the things to also consider, especially once you've got moderate and severe hypokalemia, is to give magnesium as well. Magnesium often accompanies hypokalemia. And you may find that starting off with a concurrent magnesium and potassium IV would actually bring up your potassium much faster than an isolated potassium IV on its own. So with a lot of patients who have low potassiums, we may try, for instance, for an hour or two just with potassium. And if we see that the levels are not really responsive, they're not really coming out, then we try and give magnesium sulfate as well. So again, your own institution may have its own protocols, but for us, what we'll try and do is give 2 milligrams of magnesium sulfate added in with the KCL. They do mix together, but it's better if you give them in separate lines, as an additional line or a second line, especially if you're going via CVP. And we normally give about 2 milligrams per hour. 2 grams per hour, not 2 milligrams, 2 grams per hour. And, of course, by that time you would have CMP results. You'd be able to see if you need to supplement calcium, magnesium. And if your magnesium levels are very low, you can go up to about 3 or 4 grams an hour. But majority of the time, it's going to be 2 grams per hour and not much more than that. So how do you monitor? You recheck your potassium levels every 2 to 4 hours until stable. And of course, you monitor an ECG in patients who have severe potassium depletion. Now, if your patient has severe hypokalemia, then I would suggest reducing that to even every hour to 30 minutes, depending on what you have available at your institution. So if you like us, we'd probably monitor every half an hour to an hour because our blood gas machine is just at the lab. It's a 2-minute walk, so we can afford to do it. If you don't have access to that, or you've got got to send your bloods away or whatever it may be, then you may want to, of course, do it at a more spaced out interval. Okay. So this is just the end. Just a little joke there to finish off. I hope everybody understood what we were trying to get at, and I hope you all enjoyed looking at the ECG. I'm not sure if there's any questions at the moment from those who are here on the live chat at the moment. There's not many of us, but for those of us who are here, if there are any questions or if you're satisfied with that, or if there's anything else I can add or anything like that. If you go onto our website, the Madideni Learning website, and if you go to the protocols section, I've got the management of hyperkalemia and hypokalemia. It's all in a proper protocol format that you can use. We've recently distributed the Helen Joseph protocols and the Ottawa protocols, and these also cover these topics. So hypokalemia and hyperkalemia and hypocalcemia, not so much, but maybe hypocalcemia, and of course your sodium abnormalities are the most common electrolyte abnormalities that you'll face in an emergency department. So it's the type of thing that you should familiarize yourself with if you are working in an emergency department. You don't necessarily need to know hypophosphatemia to an extreme degree, but hypokalemia and hyperkalemia, I would suggest knowing to a good degree. So I hope everybody enjoyed it, and yeah, if there's no questions, then what we'll do is that we'll end the meeting here, and yeah, then we can take it from there. Thank you very much, Leanne. I appreciate that. And yes, we'll actually end the meeting there. So thank you so much to everybody who joined. I see some of you have already jumped off. But anyway, thank you so much and keep well. Bye.